Imagine you're in the chair. The injector places this tiny, just a 0.2 cc drop of hyaluronic acid filler right in your tear trough.
Right, just a standard refresh.
Exactly. You're expecting a quick little touch-up, but then suddenly the skin of your cheek turns this stark paper white color. The pain is just agonizing.
Yeah, completely disproportionate to a normal injection.
Right. And beneath the surface, your tissue is actively suffocating. You've just entered what is arguably the absolute highest stakes scenario in aesthetics, a vascular emergency.
Oh, it's the moment every single practitioner dreads. A vascular occlusion or a VO.
Welcome to the deep dive. Today we're focusing on something that, well, anyone who even touches a syringe or sits on the receiving end of one really needs to understand at a molecular level.
Absolutely, because when that blood supply is cut off by the filler, the clock to irreversible tissue death just starts sprinting.
Yeah, sprinting is the right word. So to figure this out, we've pulled together this massive stack of sources to get you the exact evidence-based emergency protocols to reverse a VO.
And it's an incredible stack.
It really is. We're looking at medical conference abstracts from FACI, dermatology journal case reports, aesthetic clinic safety protocols, and the latest CMEC guidelines.
Right, the Complications in Medical Aesthetics Collaborative. They're the gold standard right now.
Yeah. We are looking at the absolute cutting edge here. Our mission today is to equip you with the exact emergency dosing instructions for the ultimate reversal agent, an enzyme called hyaluronidase.
Specifically, we're zeroing in on the area-based math, which is just crucial for dissolving an anterior wall HA vascular occlusion.
But before we even get to the math, we have to understand the battlefield itself, like what is actually happening under the skin during a crisis.
So a vascular occlusion basically happens in one of two ways. The filler either forms an embolus, meaning it enters the artery and physically plugs it up from the inside, or it's a large volume deposited so close to the vessel that it compresses it from the outside.
Just squishes it flat.
Yeah, exactly. The result is the same. Ischemia, blood flow is halted.
And the clinical signs map directly to that loss of blood, right? The sources highlight that initial stark whitening, which is called blanching.
Because the blood is literally gone from the area.
Right. Then, as the deoxygenated blood pools in the surrounding venous system, you start getting this mottled, purplish, sort of lace-like discoloration called levato reticularis.
Which is a huge red flag.
And then there's capillary refill. When you press the skin and wait for the pink color to return, during a VO, that refill is severely delayed.
Because the tissue is starved of oxygen. To reverse it, you have to break down that hyaluronic acid filler, which is where hyaluronidase comes in. It's an endoglycosidase enzyme.
Let's ground that term really quickly for you listening. An endoglycosidase. We're talking about an enzyme whose sole purpose in life is to just cleave or hydrolyze the specific chemical bonds that hold those hyaluronic acid chains together.
Precisely. It turns this thick structural gel back into a watery liquid that the body can just naturally flush away.
It depolymerizes it.
Yeah, depolymerizes the HA. But delivering that enzyme, that is where the real challenge is.
Which leads perfectly to my main logistical question here. If the filler is stuck inside a microscopic blood vessel, blocking it, do you have to inject this enzyme perfectly into that tiny blocked vein like a sniper?
Oh man, no.
Because mechanically, that sounds like trying to unlock a car door from the outside using a coat hanger while blindfolded in a state of absolute panic.
That is a terrifying analogy, but no. What's fascinating here is that you absolutely do not need sniper precision.
Really?
Really. In fact, attempting to fish around for a microscopic vessel with a needle, it just wastes precious time and causes more drama. This is all thanks to some groundbreaking work by researchers like Dr. Claudio De Lorenzi.
Okay, what did he find?
He demonstrated this mechanism called transarterial degradation.
Transarterial degradation, so degrading the filler across the actual arterial wall.
Yes. The concept is that if you inject a really high concentration of hyaluronidase peravascularly, meaning you just inject it into the general tissue surrounding the blocked vessel, you create this massive concentration gradient.
Oh, I see.
Yeah, so the enzyme naturally permeates or diffuses right through the intact arterial wall to reach the hyaluronic acid trapped inside. It basically attacks the blockage from the outside in.
Wow. Okay, that completely shifts the emergency paradigm. You go from trying to perform like microscopic surgery under pressure to a strategy of regional flooding.
Exactly. You don't need a direct hit. You just need to overwhelm the entire ischemic neighborhood with the enzyme.
That is the core of the current gold standard, isn't it? Because perfect aim isn't required. the whole strategy just becomes about volume and saturation.
Right. The enzyme knows how to breach the wall, but you have to provide enough of it to fuel that concentration gradient.
So what does this all mean for the actual math? Like, how much enzyme do you need to flood the zone?
Well, the sources all point to the high-dose pulse hyaluronidase protocol.
Because for years, dosing was incredibly conservative, right? Providers were using, what, 10 or 50 units?
Yeah, and failing to save the tissue. The new rule adapted by CMAC is strict area-based dosing, and the threshold is substantial.
Oh, substantial.
You need a minimum of 500 international units, or IU, of hyaluronidase for every 3 by 3 centimeter area of ischemic tissue.
Let's visualize that for you. A 3 by 3 centimeter square is roughly the size of a standard Post-it note, maybe a tiny bit smaller.
Yeah, that's a good visual.
So if an occlusion affects just one half of the upper lip, like a low-volume, single-area event, the math dictates you flood that specific quadrant with 500 units.
But ischemia often spreads along the vascular tree, like the angular artery feeds the side of the nose.
Right.
So if the occlusion starts in the nasolabial fold, and that stark blanching spreads up the nasal sidewall, you are now dealing with 2 3 by 3 centimeter areas.
And the dose literally doubles. You jump to 1,000 units.
Exactly. Depending on the geographic footprint of the skin changes, a single cycle of treatment can require anywhere from 500 to 1,500 units.
You're literally mapping the skin and calculating the dose based on the square footage of the suffocation.
That's exactly what you're doing.
Okay, let's unpack this. 1,500 units of an enzyme is a massive dose.
It is.
Because in an elective situation, like, say, a patient just wants their lip filler dissolved because they don't like the shape a provider might use, what, 15 to 30 units?
Right. A very small amount.
And we know this enzyme doesn't just eat synthetic filler. It rapidly depolymerizes the native hyaluronic acid in your own skin, too.
So with a 1,500 unit flood, what is the fibroblast regeneration timeline?
You mean how long until the skin recovers?
Yeah. How long until the patient's own tissue recovers from that kind of chemical blast?
Well, the initial deflation is dramatic. There is no denying that. The native HA is absolutely collateral damage.
I can imagine. However, human biology is remarkably resilient here. Your fibroblasts, those are the cells responsible for producing structural proteins. They are in a constant state of HA synthesis.
Okay.
Even after a massive 1,500 unit dose, the body naturally regenerates its native hyaluronic acid within 15 to 20 hours.
Really?
Yeah.
That fast. So the deflation is highly temporary, whereas tissue necrosis would be permanent.
Right. And that brings up another critical risk assessment. You'll often hear about patch testing for hyaluronidase to check for allergic reactions.
Because older formulations were derived from, like, ovine or bovine proteins, right? Sheep and cow.
Exactly. But in an occlusion, the mantra across all our sources is very clear. Time is tissue.
So you just skip the patch test entirely.
You skip it entirely. The risk of irreversible facial disfigurement is a 100% certainty if you delay. The risk of anaphylaxis is a rare statistical anomaly.
In a crisis, you do not wait to see if the skin gets itchy. You just treat the active emergency. Okay, but knowing the total area-based dose, that 500 units per 3 by 3 centimeters, that's only the first step. You also have to know how to prepare it, and crucially, how often to apply it.
Yes, reconstitution is a huge part of this.
Let's talk about that. This enzyme usually comes as a lyophilized powder, right?
Basically freeze-dried. So those delicate enzyme proteins survive sitting on a clinic shelf for months, but you can't inject powder, so it has to be mixed with a diluent, typically sterile saline or lidocaine.
And our sources highlight a few standard protocols just to keep the math simple when you're under pressure.
Right, because nobody wants to be doing complex division during a panic attack.
Exactly. One method takes a 1,500 IU vial of powder and mixes it with 10 ml of normal saline. That yields 150 units per milliliter.
Yep, very standard.
And another protocol, which is heavily cited in the Latin American guidelines, mixes that same 1,500 IU vial with just 3 ml of 2% lidocaine. That gives you a highly concentrated 500 units per milliliter.
And the choice of diluent often comes down to the practitioner's preference and, honestly, the patient's pain tolerance.
I'd imagine the lidocaine helps a lot.
It is incredibly helpful because the occlusion itself is agonizing. And then injecting a large volume of fluid into already congested tissue, it just adds to that pain. Plus, lidocaine causes a mild vasodilation, which can marginally help blood flow.
Makes sense. But the physical mixing technique is universally agreed upon, right? You swirl the vial gently. You never, ever shake it.
Never shake it. If you vigorously shake the vial, you risk denaturing and mechanically destroying those fragile enzyme proteins before they ever even touch the patient's skin.
Right. Okay, so once it's mixed, you enter the pulsed phase of the protocol. This isn't just a one-and-done injection, is it?
No, not at all. It is a relentless, exhausting cycle of intervention and observation. You flood the area with your calculated dose. Then you apply warm compresses to encourage whatever collateral blood vessels exist to open up.
Got it.
And you massage the tissue vigorously.
Which brings up an important point about the mechanism here. The sources say you observe and reassess every 15 to 60 minutes. Why the gap? Why massage and then just wait?
It comes down to chemistry and physics. The wait time is necessary because hydrolysis isn't instantaneous. The enzyme needs actual time to chemically cleave the bonds.
And massage?
The vigorous massage is required to physically break the solid filler gel into smaller microdroplets. By mechanically breaking up the gel, you drastically increase its surface area, giving the enzyme far more edges to attack.
So you're basically helping the chemistry along with blunt force.
Exactly.
And after that 15 to 60-minute window, you press the skin to check the capillary refill. If it's still sluggish or the mottling remains, you pulse it again. You repeat the entire flood and massage process up to 4 cycles.
Up to 4 cycles, yeah.
Let's make this abstract protocol deeply concrete.
Yeah.
I want to look at that case study from the Journal of Drugs and Dermatology, the 29-year-old woman.
Oh, yes.
Because it just perfectly illustrates the psychological and clinical marathon of this protocol.
It is a phenomenal example of textbook complication management. So the patient is a 29-year-old woman having her right tear trough treated.
Okay.
The injector is using a cannula, which is blunt-tipped and generally considered safer than a sharp needle. And they're using a standard hyaluronic acid filler.
And the injector even aspirated for 5 seconds, right?
Yeah.
They pulled back on the plunger to see if blood flashed into the syringe, which would indicate they were in a vessel.
Right. And it was negative.
Proving that aspiration is not a failsafe.
Exactly. A false negative is very common. So the injector deposits a minuscule amount of filler, just 0.2 cc. But almost immediately, they notice transient blanching in the infraorbital area right under the eye.
And they check the capillary refill, and it's delayed.
Over the next 5 minutes, the mottling starts creeping down her cheek toward the nasolabial fold.
So it's spreading.
Yeah. But the injector recognizes the occlusion, stops the procedure instantly, and pivots straight to the high-dose protocol.
Incredible reflexes.
Based on the size of the blanching, they calculate the dose and inject 750 units of hyaluronidase right into the ischemic tissue. They also administer 650 milligrams of oral aspirin.
And after 30 minutes of massage and warm compresses, they reassess, right? The pain has decreased and the stark blanching improved, but there is still that stubborn purplish mottling.
Meaning the tissue is still struggling.
So they don't just send her home. Over the next 2 hours, they pulse the area. They administer 4 additional injections of 250 units, spaced 30 to 60 minutes apart.
They are massaging the tissue, checking the capillary refill, monitoring her constantly for a total of 4 hours in the clinic.
Think about the physical and mental toll of that. For a tiny 0.2 cc injection, they ended up using an astonishing 1,750 units of hyaluronidase.
It's a huge amount. But because they relentlessly flooded the area until reperfusion was absolutely confirmed, she healed perfectly.
She had expected bruising, but 0 permanent scarring, 0 tissue loss, and no post-inflammatory hyperpigmentation.
It just proves the protocol works. Flooding a 3 by 3 centimeter area with massive doses saves tissue.
It does. But, injecting 1,500 units blindly into a cheek still feels like using a sledgehammer to drive a nail.
It definitely is a sledgehammer approach.
You're just hoping the concentration gradient does the heavy lifting.
As aesthetic technology evolves, is there no way to just, look under the skin and see the actual blockage?
Actually, there is, and it is actively revolutionizing complication management. High-frequency ultrasound, or HFUS.
Oh, wow.
Yeah. If a clinic is equipped with HFUS and the injector is trained in facial vascular sonography, that entire regional flooding paradigm becomes basically obsolete.
Because you put the ultrasound probe on the skin, and you can literally see the arterial wall and the exact black blob of filler compressing it? Exactly. And when you have that real-time visual guidance, the required dose just plummets. Studies by ultrasound pioneers like Dr. Leonie Schelke demonstrate that when you guide your needle tip directly into the specific filler deposit under ultrasound, the necessary dose drops from 500 units down to just 35 to 50 units.
Wow. That is a staggering reduction. You don't need a massive concentration gradient to force the enzyme across a wide barrier if you can deliver it precisely to the epicenter of the blockage.
It transforms a 4-hour marathon of pulsed flooding into a single, highly targeted intervention.
Here's where it gets really interesting, though. Until ultrasound is standard in every single clinic, the emergency kit remains your primary defense.
Absolutely.
We mentioned aspirin earlier. The sources highly recommend 300 milligrams immediately, followed by daily doses. Aspirin is an antiplatelet, so it prevents secondary blood clots from forming inside the stagnant, sluggish vessel behind the occlusion.
Which is vital.
But we have to talk about debunking some old myths regarding that emergency kit. If you look at older aesthetic forums, you constantly see people recommending topical nitroglycerin paste to dilate the blood vessels.
Oh, man. Yeah, we have to talk about that. This raises a very important warning. The most current literature is emphatic. Nitroglycerin paste is no longer recommended, and using it can actively worsen the clinical outcome.
The logic sort of sounds right at first glance, doesn't it?
Yeah.
Nitroglycerin causes vasodilation. It opens up blood vessels. If a vessel is blocked, wouldn't you want to open it up to get blood flowing around the blockage?
It's intuitive, but it's wrong.
Let's use an analogy here. Using nitroglycerin is basically like having a blockage in a narrow plumbing pipe. Instead of dissolving the clog, you just widen the pipe behind the blockage and turn up the water pressure.
Right.
You don't clear the pipe, you just wedge the clog deeper into the system.
That is an excellent way to conceptualize the fluid dynamics at play. There was this pivotal animal model study using rabbit ears.
Why rabbit ears?
Because they have highly visible vascular networks. So researchers induced a hyaluronic acid occlusion and then applied topical nitroglycerin. Because the filler particle was lodged in a tiny capillary, artificially dilating the larger arterioles upstream completely altered the pressure gradients.
It pushed the embolus further along the vascular tree into narrower, more distal areas.
Exactly. Areas that are exponentially harder to reach with perivascular hyaluronidase.
Yeah.
It resulted in a more congested appearance and actually worsened the ischemia.
So aspirin to prevent clotting, yes.
Yeah.
Warm compresses for natural, gentle vasodilation, yes. Nitroglycerin, absolutely not. Stick to the high-dose hyaluronidase protocol.
100%.
Now we've covered the lips, the tear troughs, the nasolabial folds. This is all peripheral tissue ischemia, the skin. But before we wrap up, we really have to address the most terrifying scenario in the entire stack of sources.
The eye.
What if the occlusion affects the ophthalmic artery? What happens if the patient suddenly reports blurry vision or seeing flashing lights or like a curtain coming down over their eye?
If vision is compromised in any way, it is a hard stop. You are no longer managing an aesthetic complication. You are in the middle of a critical ocular emergency. This means the filler has traveled retrograde against the natural flow of blood up into the ophthalmic circulation.
Let's explain the mechanism of how that even happens because it's wild. How does filler travel backward against the pumping of the heart?
It's just a matter of pressure. When an injector pushes on the plunger of a syringe, they are creating localized high pressure. If the needle is inside an artery, that syringe pressure can briefly overcome the patient's systolic arterial blood pressure.
Unbelievable.
So the filler is forced backward against the current until it reaches a bifurcation, basically a fork in the road, like where the facial arteries connect to the ophthalmic artery.
And the second the injector stops pushing the plunger, that localized high pressure drops. The patient's natural arterial pressure takes over again, snaps the filler forward down the new pathway, and slams it directly into the retinal circulation.
It's devastating. The sources outline the I-code protocol for this exact disaster. The window for intervention is brutally unforgiving. You have approximately 90 minutes before the retina dies from lack of oxygen, resulting in permanent blindness.
90 minutes. Now, some advanced aesthetic courses teach a technique called a retrobulbar injection. This involves taking a needle and blindly injecting hyaluronidase deep into the orbit of the eye, behind the globe itself, hoping to flood the ophthalmic artery.
Yeah, but our sources make it exceptionally clear that retrobulbar injections by non-ophthalmologists are highly controversial and increasingly discouraged.
Because it's a blind injection behind the eye.
Exactly. It is highly dangerous. Furthermore, studies indicate that even when performed perfectly, it often fails to reverse the blindness after that crucial window closes.
So what is the protocol then?
The universally agreed upon standard in the I-code protocol for an aesthetic injector is immediate rapid transfer to an emergency room with an on-call ophthalmology and retina service.
You call an ambulance? Yes. While waiting, you can administer high-flow oxygen. You can perform firm ocular massage to rapidly lower the intraocular pressure, which might help dislodge the embolus. You flood the original injection site on the face with hyaluronidase, but you do not attempt heroics behind the eye, and you absolutely do not delay transfer.
It is a sobering reality check. Aesthetics is not just, painting by numbers. You are interacting with a deeply complex, highly dynamic vascular network that connects directly to the brain and the eyes.
It's serious medicine.
Which brings us back to our primary mission today. To summarize the critical takeaways from these guidelines for you, if a vascular occlusion occurs in the skin, time is tissue. Stop injecting. Implement the immediate high-dose pulsed hyaluronidase protocol.
Map the ischemic area.
Yes, you map the area and you administer a minimum of 500 IU per 3 by 3 centimeter square. You support that chemical flood with oral aspirin, warm compresses, and vigorous massage to increase the surface area of the filler. You observe and you repeat every 15 to 60 minutes until reperfusion is achieved.
It is all about preparation, protocol, and simply refusing to panic. But if we connect this to the bigger picture of where material science is heading, it leaves us with a truly fascinating thought experiment.
What's that?
Right now, our entire protocol relies on utilizing an external enzyme to fix a mechanical blockage. We are fighting chemistry with biology in real time, relying on diffusion and concentration gradients.
So what is the alternative?
What if the hyaluronic acid fillers of the future are engineered with a built-in biodegradable trigger?
Oh, wow.
Imagine a filler that is perfectly stable under normal physiological conditions. But if a vascular occlusion occurs, the practitioner doesn't need to perform math, mix powders, or inject 1,500 units of an enzyme. Instead, they apply a specific harmless frequency of targeted light or a tuned frequency of external ultrasound directly to the skin.
And that specific energy wave acts as a key, triggering the synthetic crosslinks in the filler to instantly liquefy and metabolize on their own.
Exactly. It would make the entire concept of a vascular occlusion, the ischemia, the necrotic risk, the 4-hour pulsing protocols completely obsolete.
A true instant safety switch built into the product itself.
We are managing the complications of today's technology, but tomorrow's engineering might eliminate the complication entirely.
That is incredible to think about. Until we get those light-melting fillers, though, we respect the complex anatomy of the face, we ensure our emergency kits are fully stocked with unexpired hyaluronidase, and we remember that when the structural perfection of aesthetics breaks down, you don't need to be a sniper. You need to know how to flood the zone.
Time is tissue.
Thanks for diving deep with us. Keep questioning, keep learning, and we will see you next time.